Gallbladder removal is considered routine surgery. It's actually the most common surgery that I do. But when complications happen, they can completely change a patient's life. And today we're going to break down the complications of cholecystectomy, how often do they occur, how surgeons try to prevent them, and what procedure patients may need afterwards when things go wrong. Before we get started, let's actually define what is a cholecystectomy. Cholecystectomy is the surgical removal of the gallbladder, most commonly done laparoscopically for gallstones or acute cholecystitis. I do actually have a video talking about two things. One is going to be your gallbladder and acute cholecystitis, and the other one is actually going to be warning signs regarding acute cholecystitis, when not to ignore them. So make sure you check it out. But over 90% of these surgeries are performed laparoscopically, with conversions to open, which occurs between 5 to 10%. Overall complications are low, but they're not zero. So what are the common complications? So we're going to look at it as common, moderate complications, and severe complications. So common or minor complications may include wound infection, which occurs between 1 to 3%. And for laparoscopic surgery, they're very tiny incisions and they're pretty rare. Managing them is not going to be difficult. For those that are open, that may require more extensive debridement or dressing changes in order to prevent progression or hernia formation. Other complications include bleeding or hematoma. Well, the bleeding, when we look at it, it could be minor, it could be major, because a bleeding could be a small thing that you develop a hematoma under, or you could be actively bleeding requiring a take-back with surgery. Other complications include postoperative pain or ileus, which we notably see when there is really severe inflammation or of your gallbladder or a lot of spillage of contaminated bile. Lastly, diarrhea and bloating. Many patients experience post-cholecystectomy diarrhea due to continuous bile flow into the intestine. Bloating is actually fairly common, which is up to 40% of patients. Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going. Now moving on. Moderate complications. Well, we talked about minor. Moderate complications actually include bile leak, which occurs between 0.3 to 2%. But where do they come from? Well, they could either come from a cystic duct stump leak when your clip falls off or you didn't clip it properly, or accessory ducts like the duct of Luschka. So you get your critical view safety, you clip your tubular structures, your cystic duct and cystic artery, and you didn't notice as you're dissecting that there was an aberrant duct posteriorly, and that may cause a bile leak. Other things include intra-abdominal abscesses, which a bile leak can actually cause, or spillage and contamination, and retained common bile duct zones. We do look at when we perform cholangiogram in patients selectively, and so those people who may have gallstone pancreatitis, those people with an elevated bilirubin and a large duct are people who we suspect, so we do them selectively, but that does not guarantee that small amount of people may have occult stones, which may not be manifesting any ductal obstruction or elevation in your bilirubin. How do these patients present? Well, they would present with symptoms of abdominal pain, fever, jaundice, or persistent nausea. Now moving on to major and life-changing complications. This is something that we dread and we try to avoid. First of all, bile duct injury, which occurs at 0.2 to 0.5%. Vascular injury, more commonly the right hepatic artery injury, because that's actually just under the hepatocystic triangle, and that's the origin of your cystic artery. So doing a careful dissection, avoiding any injuries there is of paramount importance. Bowel injury, and lastly, sepsis. Bile duct injury is the most feared complication, and it is associated with long-term morbidity and multiple future surgeries. So why do complications happen? Well, there are going to be key risk factors. One is going to be acute or chronic inflammation, severe scarring or fibrosis, When a body habitus is obese, that actually makes the surgery more difficult. Aberrant biliary anatomy, understanding that a variation in anatomy exists, and so understanding what you're clipping and cutting is very important. Surgeon inexperience. Interestingly enough, when they actually looked at it before to look at when general surgeons actually have their bile duct injuries throughout their practice, what they noticed is sometimes as the surgeons progress throughout their career, their attention to detail may be lower because now they're looking at it as another routine cholecystectomy. And when you're not paying attention to every single detail, a cholecystectomy may become dangerous because of the risk of complication of misidentification. Lastly, emergency surgeries, because this tells you of how bad the pathology is, and with the patient septic, with gallbladder perforation and acute on chronic inflammation, that may actually make surgery a lot more difficult and the risk of injury higher. Anatomic variation is common, and up to 30% of patients have atypical biliary anatomy. So, how surgeons prevent complications? Number one, critical view of safety. Clear identification of your cystic duct, cystic artery, and gallbladder separated from the liver bed. Typically, we clear the hepatocystic triangle and separate the lower third of your gallbladder from the cystic plate, and ensure that there's only two tubular structures entering it, with the liver seen from behind it. Other prevention strategies include considering use of cholangiography. However, if you misidentify the common bile duct as your cystic duct, doing a cholangiogram and that aspect already led you to an injury. So it doesn't replace being a meticulous dissection to avoid those injuries. It does identify it, but nothing replaces proper identification. Understanding when to bail out, whether you do a subtotal cholecystectomy or a conversion to open. Avoiding blind clipping, and then calling help early when it becomes overwhelming. Prevention is the key, and knowing the anatomy is more important than speed. So, what procedures are done after complications? So, ERCP number one, and you may also check out our video comparing it ERCP versus MRCP. Also associated with the other video that we had. What is it used for? For bile leaks, retained stones, and for stent placement. What are the risks? Pancreatitis, which occurs in 3 to 10%, bleeding, or perforation. Percutaneous drainage. When is it used? For abscesses or biloma. Other fluid that may actually present is actually bleeding, and that will reflect on your CBC with a low hemoglobin and hematocrit. When do we have to reoperate? Well, when there are major bile duct injuries, bowel or vascular injuries, or active bleeding. This may require a Roux-en-Y hepaticojejunostomy, which requires lifelong follow-up. The more important thing is when you get faced with this major injuries, you have to do damage control and then have a hepatobiliary surgeon do the repair properly. Because if you do this once a year or have not done it, do not do it to the patient because it will only complicate the surgery in the future. You're only threatened with more complications down the road, which makes repair more difficult. So what happens to patients who have bile duct injuries and end up with repairs? Well, there's going to be long-term impact on patients, and some patients develop chronic abdominal pain, recurrent cholangitis, strictures, nutritional issues, anxiety, or reduced quality of life. This is why early recognition and referral to hepatobiliary specialist is critical. Examples for those students and residents, which are high-yield takeaways. Bile duct injury rate is 0.3 to 0.5%. Most bile leaks are treated with ERCP. Right upper quadrant pain plus fever after chole, think about a bile leak. Critical view of safety prevents disasters, and early recognition saves lives. Gallbladder surgery is common, but complications are serious when missed. Understanding them makes you a safer clinician, surgeon, and advocate for your patient. If you guys liked the video, please click the like and subscribe button, And tell us through the comments what your experience with doing the surgery, or if you're the patient, how did you feel after the surgery? For those people who have undergone complications, would also like to understand what bailouts or how was it managed. And check out our other videos, and I'll see you guys next time.